Coming up on Mayo Clinic Q&A.
We have evidence that a small number of cells in the heart can be infected directly by the virus. And a small number of people can get what is known as myocarditis in the context of an actual viral infection. However, the majority of people who have any evidence of cardiac injury, and I would emphasize that's a minority of people infected with COVID, have other forms of cardiac damage.
Myocarditis is an inflammation of the heart muscle and can occur after a viral infection, such as COVID-19. But in most cases, the risk of complications due to the vaccine is very low.
The likelihood of a bad thing happening, a hospitalization or dying from the virus itself, is greater with the virus than it is with a vaccine in every case, every analysis, in every study done.
Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. Well, we understand that COVID-19 is a respiratory virus. We now also know that the disease can affect many organs, including the heart. Individuals with heart disease are at increased risk of more severe complications from COVID-19, but anyone infected with the virus can be at risk for problems with their heart. Here with us to discuss this topic today is Dr. Leslie Cooper, the chair of cardiology at Mayo Clinic in Florida. Thanks for being here today, Leslie.
It's great to be with you. Thanks so much.
Well, I think this is a really interesting topic to people. We hear so much about what's going on with COVID-19 itself and with vaccination, so I'm excited to tackle the topic today.
Yes, it really is timely. Not only have we learned that COVID-19 can cause cardiac injury through multiple mechanisms, but the virus in rare cases, particularly in young males, can cause myocarditis, a specific form of cardiac injury.
So Leslie, does COVID-19 directly damage the heart, or is it an indirect mechanism?
That's an area of controversy currently. Certainly, we have evidence that a small number of cells in the heart can be infected directly by the virus. And in a small number of people can get what is known as myocarditis in the context of an actual viral infection. However, the majority of people who have any evidence of cardiac injury, and I would emphasize that's a minority of people infected with COVID, have other forms of cardiac damage. For example, they could have a heart attack from a blocked artery, or they could have damage from the systemic illness called a sepsis, but not a direct virus infection.
So is that what myocarditis is?
Yes, myocarditis is either a direct injury from the virus in one case, or in the case of the vaccine, it could be an allergic reaction, sometimes called a hypersensitivity reaction to the vaccine.
And what is this a long haul symptom when COVID affects the heart, or is it a different issue?
Great question. So long haul COVID, which is extending symptoms such as fatigue or shortness of breath, or sometimes chest pain beyond 4 to 6 weeks, particularly 3 to 6 months after the initial infection. That is caused by multiple mechanisms. We know from studies in children as well as in adults that the heart can be a bit stiffer and it doesn't relax as well following COVID infection in people who have symptoms. We also know from studies in Europe that that the risk of long COVID symptoms increases with higher immune reactions. So the immune reaction against the virus spike protein tracks very closely with more severe and extensive long COVID symptoms.
Leslie, I understand that many individuals who are infected with COVID-19 experience shortness of breath. And so how would an individual know if they were at risk of a heart issue from COVID-19? What would that look like?
Such a good question. As you point out, COVID can affect the lungs and it can affect the heart. And the illness itself, when you're sick, leads to deconditioning because you are not as active as you were. So going back to activity has intrinsically a ramp up time. So it's hard for the individual to tell which is the cause of your symptoms. Is it the heart, the lungs, or deconditioning? I would recommend seeing a medical provider. If you've still got symptoms, we can sort that out with generally non-invasive and simple testing.
Now, I understand that you studied myocarditis in an interesting population, athletes. Tell us a little about that.
Yes. In the beginning of the pandemic, we saw that there were abnormal MRI findings in young people. These The most people who are sick from the virus are older people who've had pre-existing heart conditions like blocked arteries or hypertension. However, in young athletes who have no previous heart disease, we also saw abnormalities on cardiac MRI, which is a test which can tell if there's inflammation in the heart. Now, the rate of that was pretty low. It was between 3 and 15% in the early studies. What we learned was that there are features that normal athletes have on the MRI that did not mean they had any damage in the heart, but we'd identified those. And once that substantial group was subtracted from the MRI studies earlier this year, we learned that it is only between 1 and 2% of actual athletes who have any MRI evidence of inflammation following the virus. Now, is this meaningful? Will this cause an arrhythmia, sudden death, or heart failure? The vast majority of cases, the answer is no. The vast majority of these patients, the young athletes who have MRI findings that are abnormal, have no symptoms at all. 75% have no symptoms, and the ones that do have mild symptoms. We recommend that in young athletes who actually have COVID involvement in the heart, that they abstain from competitive sports for 3 months, and then they can return after evaluation.
So 3 months, do we know how long this lasts? Is 3 months the duration or less?
We base that number on studies from other viruses. So what we had described many years ago was the duration of virus damage in the heart in most people who recover. And the range is between 3 and 6 months in most people. A few people have longer term injury. But in the athletes, we extrapolated from the previous data to the COVID data, and we're still waiting for some longer term serial MRI studies to make sure that we picked the right number. 3 months appears to be about right.
One of the questions that we hear frequently, Leslie, and that is often bandied about even in the out on the web is, what about vaccinations? Are vaccinations placing people, particularly the mRNA vaccination, placing people at risk for heart issues? And what's the risk-benefit ratio?
Absolutely. So the actual calculation depends on how virulent the virus is, the prevalence of the virus in the community, and the susceptibility of the individual to viral damage. So an 80-year-old person in a community with a high prevalence of a serious virus would always want to be vaccinated, because the risk of the vaccine would be very, very much lower than the risk of the actual virus. And so thinking about those variables, in all women over the age of 12 and in all males over the age of 30, there's really the competing risk is invariably in favor of vaccination. The likelihood of a bad thing happening, a hospitalization or dying from the virus itself, is greater with the virus than it is with a vaccine in every case, every analysis in every study done. Now, the rate of vaccine-associated myocarditis in young males between the ages of 16 and 19 is about 6,000, 1 in 6,000. That's still a very low number compared to the risk of an adverse event from the virus itself, even in a young and healthy population. And so most people who have vaccine-associated myocarditis are males, 80% male, and it's 80% or so after the second vaccine of the 2-dose mRNA vaccines. And so with that framework, I would simply say in every population that's looked at, it's still in favor of vaccination, although the degree of benefit is probably lower in the young males than it is in every other group.
Leslie, an interesting question from one of our listeners. They had heard that if the mRNA vaccine was accidentally injected into a vein while the vaccination was being administered, that it could increase the risk of cardiac complications.
That's a really interesting idea, and we've discussed that in various groups that make recommendations about the mRNA vaccines. It was thought that theoretically young male athletes would have greater venous drainage from the arm, and that the chances of injecting into a vein were greater, and that therefore the injectate, the vaccine would go to the heart as opposed to into the muscle of the arm. And so there's no data for that. And so we don't have, it's a theory. And I think the chances of that happening are very low. If there's any uncertainty, you can pull back on the syringe a little bit to make sure you're not in a vessel. But the actual risk of that happening, I think, is quite low. And the theory that you would have a specific cardiac injury because of it remains only a theory.
We continue to learn so much about this virus, and I'm wondering, what do you think the future looks like for people who've had COVID-19 in terms of heart disease? Will there be long-term effects on the heart?
Yeah. So the question here is, if you had COVID and you recovered, are you at greater risk in the future, either from a vaccination or from another virus or other just long-term heart damage? And I think that as far as we know today, there is, in people who recover symptomatically, there's no long-term risk that we know of. There are multiple prospective studies that are looking to answer that question with serial MRIs. They have not yet been published. I think the other question, if you're in the minority of people who has long COVID, what is the duration of long COVID and what is the mechanism of long COVID? Now, those are terribly important questions that are still unanswered.
Interesting. Well, so much more to discover. I've been amazed, Leslie, over the past year at the incredible burgeoning of information that has happened within the scientific community, and there is still more to discover, it sounds like.
There certainly is, and there's a lot of work being done at Mayo Clinic and elsewhere to understand this illness, this virus, and the long-term impact of it. It's great to be a part of this medical center and this community, because we've been able to contribute so much specifically on this question.
Well, thank you so much for being here to talk to us today, Leslie.
It's my pleasure. Thank you so much. Have a great day.
Our thanks to Dr. Leslie Cooper, Chair of Cardiology at Mayo Clinic in Florida, for being with us today to talk about COVID-19 and the heart. I hope that you learned something. I know that I did. We wish each of you a wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts.